So ANAs, up until I think 1990, were done on rat liver cells. And they would take the cells and you stick them on a slide, alcohol fixed them to the slide. The problem with and they work pretty well, except that you could never be completely sure if the rat cell that you were using was expressing all the antigens that you would want it to express in a human. And so sometime in the early 90s, they switched to human epithelial cells. They're basically cells that are immortalized. They're cancer cells from some poor schmuck back in the 90s, and the line is still going. And they've made a couple of improvements as the years go on, and now I think the current generation is Hep 2000 cells. And presumably, and sensitivity has gone up, because presumably those human epithelial cells do produce all the antigens you would want to compared to your patients. And so they take these human epithelial cells and they're fixed to slides, and then you take the patient's serum and react it over the slide. If a patient has a high titer ANA, say 1 to 1280, they had to do this. They did it at 1 to 40, 1 to 80, 1 to 160, 1 to 320, 1 to 640, 1 to 1280, and then they saw it disappear at 1 to 2560. So they did this 7 times to finally come to the ANA titer of 1 to 1280. So it's expensive and it's labor intensive. So then you're halfway done. This is half of the ANA. The first half is the immune fluorescence. It tells you that, yes, something lit up, and it tells you the titer. So what do you do with that? Well, we know that some patterns have some clinical meaning. Not great, but some. They may give you some extra information. So this is what the tech will see in the fluorescent microscope of the positive ANA. And this is, doesn't show it very well, but this is smooth. The nucleus is lighting up homogeneously. So these are the nuclei. The cell body would be out here in the dark area. So this is just the nucleus lighting up smoothly. You'll see this called smooth, homogeneous, or diffuse. This is probably the rarest pattern. This is RIM. And this is probably reacting against some aquaporin in the cell nucleus. This is the most common pattern that you're likely to see. This is speckled. You'll also see it called granular. And some people in some labs will further subdivide this into fine speckled or fine granular or coarse granular. And they'll say that you can make some predictions based on that. I'm not sure I believe those. They just report speckled or granular at our lab. This is nucleolar. So this here, the nucleus is not lighting up, but the nucleoli are. This is centromere. This is the only pattern that is by itself can give you a diagnosis. What disease is associated with this ANA pattern? Anticentromere. Scleroderma. What kind of scleroderma? Right, limited cutaneous scleroderma crest syndrome. So that's the first part. You've done your immune fluorescence. You have your titer. You have your pattern. It would be nice to know what antibody is actually causing that pattern, because that could give you some better information. So then the next half of the test is your standard ELISA, where you have the known antigen in the bottom of the well. You react the patient's serum, and then you have a developer, either an enzymatic substrate or immune fluorescence, and then you can tell if you've identified an antibody that might be helpful. And so here we have some of the patterns and the disease most closely associated with that pattern, but these are far from perfect. These are just kind of general guidelines. But if you have a smooth, diffuse, homogeneous pattern, your antibody, if you're going to catch one, is probably going to be double-stranded DNA or antihistone. Speckled can pretty much be anything. Nucleolar typically is going to be a systemic sclerosis spectrum disease, but not always. And then we already said centromere is basically going to be limited cutaneous scleroderma. So if you have this, you're done. You don't really care if you have an antibody or not. You're probably going to have an anti-centromere antibody, but you don't care. You can pretty much stop when you have the anti-centromere pattern. These, you probably want to do further testing to identify the antibody. And then these are just some of the antibodies that are associated with different diseases, and you've already heard this in bits and pieces from other lectures, but it's a long list. So basically, double-stranded DNA histone associated with SLE, drug-induced SLE. So some labs are trying to save money by skipping the immune fluorescent phase. So when you're out in private practice and you order an ANA, try to make sure that they actually do the immune fluorescent pattern first, because some are trying to shortcut this. And what they'll do is they'll do the ELISA test, and they'll check for all these antigens or all these antibodies. And then when the antibodies come back negative, they'll report that as ANA negative. Well, that's not ANA negative. They just didn't have one of these antibodies that we can identify. But they could totally still have a high titer ANA and not have any of these antibodies. So that's an ongoing controversy for rheumatology. And then we know that the ANA by itself is not a particularly good test. It's not particularly helpful. It has pretty lousy specificity. And this was a study, there's lots of studies that have shown this. This is just one I picked. This was a Japanese study a few years ago. As you get older, if you live long enough, basically you're going to get an ANA. 36% of patients, 17% of patients over 85 had a positive ANA. Generally, I tell patients 5 to 10% in healthy populations. When they come in referred for a positive ANA, I'll say, yeah, you have a positive ANA, but so does 5 to 10% of people walking around in Walmart right now. And then this was a study done a couple years ago that was done out of frustration, I think. It was kind of a funny study. It was a couple of private practice, community-based rheumatologists who were in the same boat all rheumatologists are, where you get a ton of referrals for positive ANA. Patient elbow hurts, get an ANA. Patient has a sore throat, get an ANA. And so that what they did was, it's not a great study, it's not groundbreaking, but it was interesting. And they basically looked at all their referrals for positive ANA, stratified it into titer, went back and did a chart review, tried to figure out if those patients actually had disease. And what they found out was that the positive predictive value of a positive ANA was just laughable. Even at high titers, even at a titer of, say, 1 to 320, the positive predictive value was 4%, so less than 5%. So if you have no reason to check the ANA, and you check the ANA, even if it's a high titer positive, the chances are still pretty low that the patient has lupus. Interestingly, they also stratified this according to who referred it, which played a big role, as you can imagine. And when these patients came from an internist, the positive predictive value was much higher. When it came from a nephrologist, it was even higher. When the referral came from a nurse practitioner, it was quite low. So do with that as you will. A lot of patients will complain of a flu, and it's common enough where it's known as methotrexate flu, kind of a flu-like achy myalgia for the day or two after they take it. The main toxicity that we see, the most common, is hepatic. Don't really know how that happens, so we monitor AST and ALT, liver function. One of the most dangerous ones is pneumonitis. It's an idiosyncratic reaction, and it typically will happen early in the methotrexate course, and the patient will come in with, diffuse pulmonary infiltrates, fever, bone marrow suppression we always have to worry about, and pulmonary fibrosis is controversial. Now, this pulmonary fibrosis is different from the pneumonitis. The pneumonitis is a real thing. It does happen. That's not controversial. Pulmonary fibrosis, if you ask a pulmonologist how many patients they have on methotrexate who have pulmonary fibrosis from it, they'll say, oh, a ton. If you ask a rheumatologist, they'll say, I don't have anybody. And the problem is that if you compare, most of this pulmonary fibrosis from methotrexate is found in patients with RA, and we know that up to 30% of patients with RA will get pulmonary fibrosis. So is it the methotrexate or is it the natural course of their disease? When you look at patients who were taking methotrexate for psoriatic arthritis, they don't get pulmonary fibrosis. So it's still controversial, but I think we sort of overstate the pulmonary risk of methotrexate. Having said that, if I have a patient with pulmonary fibrosis, I typically don't put them on methotrexate because they'll just confuse the picture. If you've seen us, if you work with us in clinic, you know that we basically check CBC and it's supposed to be CMP every 3 months. Technically, according to the textbooks, it's supposed to be quicker. But as the years have gone by and we've gotten more and more comfortable using methotrexate and not had a lot of toxicity, I think most people now would check no more frequently than every 3 months. Obviously, if you have a patient who you're concerned may be drinking or something, you would check more often. And then we also have to watch renal function because methotrexate is renally cleared. So if you're concerned about the patient's what can happen, we had a patient, I don't know if anybody had this patient just recently. We put her on methotrexate back in January, I think, and she was doing fine. And then she got sick. She got a GI bug or something, and she puked her guts out for a week and was laying around and got dehydrated. But continued to take her methotrexate, even though we typically tell patients if you get sick, if you get a fever, if you get antibiotics, surgery, don't take your methotrexate. But she was a good patient and kept taking her methotrexate. And so by the time she got admitted, I think her creatinine was 7, and her white count was essentially 0. Because she wasn't renally clearing the methotrexate, it caused bone marrow suppression. Now, thankfully, her bone marrow is recovering, but that's sort of a next to liver dysfunction. That's our other big concern with methotrexate. And I really will not put elderly patients on methotrexate, or I'll think really hard about it, because in an 80-year-old, even if they have a creatinine of 1. Their renal function is just so unpredictable. Best to avoid it. One other thing that was an issue with this patient in particular in the hospital is what do you do with methotrexate toxicity? Because if you look up, the leucovorin is the rescue drug. But if you look up leucovorin, it's based on serum concentration, how you give the leucovorin. And in this patient, she had taken her methotrexate on like a Monday, I guess, and she got admitted on a Friday, and her methotrexate serum level was 0. And so pharmacy said, well, she doesn't need leucovorin, we're not going to give her leucovorin. Well, the problem is that your serum levels don't necessarily reflect your intracellular levels. Methotrexate is essentially an intracellular drug. It's taken up and then polyglutamated and trapped in the cell. And so your serum level may not be very helpful. It will reflect, if it's positive, it will reflect that they're taking their methotrexate. But if it's 0, you just may have missed it. So keep that in mind. If you have a patient with a methotrexate level of 0, but you strongly suspect has methotrexate toxicity, go ahead and do the leucovorin. Our replacement for methotrexate is leflunomide, Araba. You'll see this a fair amount out at the VA when you rotate through with this. It's essentially methotrexate light, and you can pretty much substitute it for most of the places we would otherwise we use methotrexate. It also has nearly identical toxicity profile, again, including possible pulmonary fibrosis, but the same story. It just so happens that we're using this drug in patients who were going to get pulmonary fibrosis anyway. We do know how it works. It's a dihydroorotate dehydrogenase inhibitor, so you decrease pyrimidine synthesis. Lymphocytes don't have a salvage pathway, so anything that reduces pyrimidines or purine metabolism in lymphocytes makes them more likely to apoptose. They're more sensitive to it. And so you basically off T cells and B cells. Dosing is 20 milligrams a day, typically. You can use this with methotrexate, which we do sometimes. You just cut the dose in half. We already talked about toxicity. The monitoring, again, in real life, it's the same as methotrexate. We would check every 3 months. The advantage of leflunomide is that it is not renally cleared, and so it's much safer to use in patients with iffy renal function. And so you'll see this at the VA a lot. The downside with leflunomide is that because it's not renally secreted, it is hepatobiliary recirculated over and over and over and over, and has an extremely long half-life. Up to 2 years. You can still measure leflunomide levels after someone has stopped the drug. So if they have a problem with leflunomide, or they decide they're going to get pregnant, it's a huge pain. If you got to get rid of it, there's a cholestyramine washout process. There's an 800 number that you have to call the company. They send you a kit, and you check a level, and then you have to do cholestyramine again. You check another level, and you have to keep doing that until your level is undetectable. It's a big pain. So basically, no leflunomide in children, childbearing ages. But otherwise, it's a pretty good drug. Our other major DMARD, oral DMARD, is sulfasalazine. Almost never used by itself. It's not a very good drug by itself, but we use it in combination therapy a fair amount, mainly NRA. And then we sometimes will use it in patients with spondyloarthropathies with significant peripheral arthritis. It has shown some effect in peripheral arthritis. It doesn't do anything for the axial symptoms, but it does help with the peripheral arthritis. Like methotrexate, we really still don't know how it works. It's felt that it alters gut flora. It may downregulate inflammatory mediators, but the bottom line is we really don't know. There's the dosing. Again, the main toxicity is GI upset. like it is with most of our drugs. So we usually start low and work up, titrate up on the dose as their stomach will let us. The risk is cytopenias. Don't see it very often, but it can happen, especially if they're on another agent that can cause cytopenias, like you put them on, a Bactrim or Methotrexate or another marrow-suppressive agent. And it can cause oligospermia in men. The monitoring, it's not as toxic or not felt to be as toxic as methotrexate or leflunomide, so maybe twice a year, 3 times a year, I'll check a CBC and a CMP if someone's on sulfasalazine. Usually it's not an issue because they're on methotrexate or something else with it, and so they're getting their labs more frequently because of that. Fentanyl is our other favorite medicine. Its main use is in lupus, but we also use it as a lot in rheumatoid arthritis and combination therapy. You'll hear us talk about triple therapy, which is methotrexate, sulfasalazine, and Plaquenil together. And we have pretty good evidence that those 3 DMARDs together are as good, at least in early RA, as biologic therapy. And they're a heck of a lot cheaper. So we use a lot of triple therapy. But the main use of Plaquenil is still lupus and lupus-related conditions like discoid lupus, Sjogren's, which is a lupus cousin. Its mechanism, it probably acts through a couple of different ways. It increases the pH of cytosolic vesicles. It sort of interferes with the garbage disposal system of the cell. And it's felt that if you interfere with that, then the cells can't process antigens and load them onto MHC2 receptors. So Plaquenil probably interferes with that. It blocks toll-like receptors, 7 and 9. Those are the non-specific pattern recognition receptors. And then we use it for antiphospholipid syndrome because it seems to block one of these phospholipid mediators that is involved in antiphospholipid syndrome. It's once a day, 6.5 milligrams per kilograms daily. The usual dose is going to be 200 to 400 milligrams. You want to dose it on ideal body weight, not their actual body weight. If you look at the literature on patients who have gotten the retinal toxicity from Plaquenil, most of them are overweight and were dosed on actual body weight. So they were overdosed by quite a bit for years and years. If you don't want to do it by weight, you could just say if they're taller than 5 feet, give them 400 milligrams, and if they're less than 5 feet, give them 200 or 300 milligrams. Nausea and vomiting, like all of our drugs, is the most common side effect that we see. Again, we usually start at a half dose and work up to the full dose, and that gets better. The retinal toxicity is the most feared and the one that you'll see on boards. The code words that you'll see are bullseye maculopathy or retinal pigment epithelial cell depigmentation. They can get some corneal halos. So I think the guidelines are eye exam at baseline and then annually in high-risk patients or after 5 years. I think most patients end up just getting annually because I think the American Ophthalmology Association recommends annual eye exams anyway over a certain age. So most of them we have them see annually. The worst toxicity of Plaquenil, which we almost never see, is this weird myopathy / cardiomyopathy, and it does happen. It's out there. It's been fairly well described. It's almost like an inclusion body problem. And it probably results from this blockage of the garbage processing function of the cells. If the cells can't process the garbage, presumably there's something that builds up and causes toxicity to the muscle cells. What to do with that, I don't know, because I haven't used much of this drug. I don't think I have anybody on it right now. If they did have elevated total cholesterol, I don't know what I would do with it. I'd probably send them to somebody else because I haven't started someone on a cholesterol medicine in 14 years. So tocilizumab is indicated for rheumatoid arthritis. It's an IL-6 blocking disease. It's a human antibody to IL-6, and IL-6 is like TNF. It's a key cytokine with rheumatoid arthritis. So its main use is rheumatoid arthritis. It also is used. I don't think it's indicated for Still's disease, either in kids or in adults. It's IV dose monthly. Like all of our biologicals, the main toxicities are infections. It can cause neutropenia and LFTs along with the elevated total cholesterol. So the monitoring is CBC and lipids. Good medicine. You'll probably see a lot more of it. It's one of these drugs that seems to be... There's some biologicals that they seem to work everywhere that you try them, and this seems to be the case with tocilizumab. It seems to work really well, especially in patients who may have failed a couple of biologicals already. Tocilizumab seems to sometimes work really well. So allopurinol, It's a purine analog, xanthine oxidase inhibitor, but it also inhibits the metabolism of azathioprine and azathioprine's active metabolite, 6-mercaptopurine. So it's not absolutely forbidden that you use them together. If you absolutely have to, I'm not sure. I've never seen anybody do that. It would be a pretty gutsy move. Usually, the one thing you're trying to prevent with allopurinol, it's a pretty safe drug, but there is this weird idiosyncratic hypersensitivity reaction, which is like a DRESS syndrome. Fever, rash, hepatitis, renal failure. They're just really sick, and this could kill them. And so this is what you're worried about with allopurinol. And there's pretty good data to show that if you dose them appropriately for their renal function, you can avoid this reaction. And this reaction tends to happen pretty close to the onset of when you start the drug too. So if you've had somebody on allopurinol for 5 years and they get a rash, it's probably not this. But you have to be careful with allopurinol to start at an appropriate dose for their renal function to avoid that. And it's been shown that if you start 1.5 milligrams per unit GFR, then you're pretty safe. You're probably not going to have problems. So if their GFR is 50, your starting dose would be 75. So you're looking at 50 milligrams. Main toxicity is the hypersensitivity syndrome that we've already mentioned, rash. It can be bad, Stevens-Johnson's. Occasionally cytopenia, especially if you are trying to use it in somebody who's on azathioprine. The main risk is renal function, so we typically will check their renal function every once in a while when you have them on allopurinol. We tend to underdose allopurinol. Once they've demonstrated that they are not going to get the hypersensitivity reaction, we're much more aggressive about it going up on the dose, even if they have renal failure. So I'll see patients who have renal failure and terrible gout, and they're on 100 milligrams of allopurinol, and they've been on that for 5 years. Well, it's okay. You can push the dose. It's not a problem. It's standard of care now. I don't know how many Han Chinese you're going to treat, but in Southeastern Asian populations, they have this HLA association that makes them much more prone to get this. And so it's standard of care now in these folks that there's a test you can check. You can check this HLA subtype. You check this first to make sure they don't have it before you start them on allopurinol. And it's common enough where it's easy to do, and it is standard of care now. So while we're on azathioprine, not used as much anymore. Not used as much as we used to because we have better drugs available. Its main use is in lupus and lupus complications. I think the gastroenterologists still use it a fair amount for IBD. It's a purine inhibitor. We've already had a pyrimidine inhibitor. This is a purine inhibitor, and we already discussed how that affects your lymphocytes. It's actually metabolized into these thioguanine metabolites, which are then taken into DNA and poison the DNA and cause apoptosis. So usual dose, 2 to 2.5 milligrams a day. You want to check a TPMT level first, although I wouldn't say it's standard of care yet. It's still somewhat controversial, and that's because of this. So here you have azathioprine, and normally it gets converted. This is how it works for, let's say, our lupus patients. It gets converted by this enzyme. It goes down this pathway, becomes a thioguanine monophosphate, and then is taken up as a nucleotide into DNA and kills the lymphocyte. But some of it is metabolized out by xanthine oxidase. So if you have somebody on allopurinol, you block this, and so now everything is shunting this way. So that's going to cause bone marrow suppression. And then a fair amount of it is also metabolized by TPMT, thiopurine methyltransferase. So 90% of everybody has a normal TPMT, but 10% don't. And so if you give someone who has a low TPMT level, they don't have a very active TPMT enzyme, then this pathway doesn't work, and then again you get more shunting down this pathway and you get bone marrow suppression again. So typically these days we check TPMT activity before starting a patient on azathioprine. The jury's still out whether you need to do that. Is it cost effective? Because we know that even in patients who you check a TPMT and it's normal and you put them on azathioprine, some of those patients are still going to get bone marrow suppression. So even if you do everything right, it's still a problem. So it's still controversial whether you should do this or not, whether it's cost effective. It's an expensive test. It gets sent off to a specialty lab. It takes 2 or 3 weeks. The patients can't afford it if their insurance doesn't cover it. So that's still a problem. So we already mentioned the main toxicity is myelosuppression. Again, nausea and vomiting. All of our drugs cause nausea and vomiting. This is rare. And then elevated LFTs, like with methotrexate, can be a problem with azathioprine. And so the usual monitoring is the same as with methotrexate, generally renal function and liver function studies every 3 months. Any questions? If you have any questions at any point, just raise your hand or yell. Okay, we already mentioned allopurinol, and this is its cousin, febuxostat. There's really no good reason to have someone on febuxostat that we know of. It's more expensive than well, I take that back. It's more expensive than allopurinol, and there's no good data to suggest that it works any better. The commercials are effective. We will get a lot of patients who were on allopurinol, and then they'll say they had a flare because of their allopurinol, which really wasn't their allopurinol. They just weren't put on prophylaxis, and they'll get switched to febuxostat. It is similar to allopurinol in that it is also a xanthine oxidase inhibitor, but it's not a purine analog. It's just a straight inhibitor. But it also inhibits, because it inhibits xanthine oxidase, you get the same problem with febuxostat that you do with allopurinol. So the same problem with metabolism of azathioprine. The dosing is usually, you start 40 milligrams a day, and then maximum dose is 80 milligrams a day. It can cause some LFTs, rash. And unfortunately, if there's some case series that suggest that if they have a severe rash with allopurinol, they're not likely to have the same rash with febuxostat. But there are patients who will. So if someone has a life-threatening rash to allopurinol, maybe you could put them on febuxostat, but it may be tricky. Questionable increased cardiovascular adverse events, watch renal function, and OFTs. We already mentioned Christexif, pegloticase, briefly. Urate lowering agent, recombinant porcine uricase. It's an IV infusion, mainly infusion reactions, and precipitating a gout flare are the biggies. Generally, you don't give this if they have any kind of cardiac toxicities because of the high risk of infusion reactions. So it's in the patients who need this most that you can't give it, because it's typically the 70-year-old VA guy with bad kidneys and 6 stents who's got tophaceous gout. He can't get this drug because he's got too many comorbidities. But every once in a while you'll have a young patient who has some sort of urate metabolic genetic deficiency. They're good ones to use this drug in. You monitor this by checking a uric acid level prior to giving them the infusion. And if you notice that the uric acid level is trending up before you give it, then you think to yourself, well, maybe the drug is not working as well because they're developing an antibody to the drug. Because everyone will develop an antibody to this drug since it's a pig product. And so that's when they get the severe reaction. Is once they've made antibodies to this drug, that's when they get the severe infusion reaction. So that's how you know when to stop Christexif, when their uric acid level starts to trend up. And sometimes that may be only 1 or 2 infusions. Colchicine is our other gout drug. Pseudo-gout. It's used for some of the autoinflammatory diseases as well. Familial Mediterranean fever can sometimes be useful with Behçet's for the oral and genital ulcers, aphthosis. There's some evidence to support its use in idiopathic pericarditis. It's another one of these drugs that we have a lot of presumed mechanisms, but nobody really knows for sure. For acute gout, you give 2 pills together, 1.2 milligrams, and then you give another pill an hour later, and then the daily dose is either 1 or 2 pills a day, 0.6 milligrams, 0.6 milligrams once a day or twice a day. The prophylactic dose is once a day. And then the dose is generally twice a day for familial Mediterranean fever or to prevent ulcers in Behçet's. It used to be, when I was a resident, you would give them, if someone had a gout flare, you'd basically give them colchicine until they puked their guts out and they couldn't tolerate it anymore. But we've gotten away from that, so now it's a much more humane regimen. The main toxicity is GI, particularly diarrhea. Some patients just will not tolerate it at all, even once a day, because of diarrhea. There's a risk of myelosuppression and neuropathy. They're rarer. They happen more in patients with renal failure. So you watch renal function. If they have bad kidneys, then you just cut the prophylactic dose in half, or you can put them on twice a week if they're on dialysis. And as you know, or as you may know, colchicine used to be 4 cents a pill Now it's $4 a pill. It's Colchicine. The generic is no longer available due to some unforeseen effects of a law that Congress passed a few years ago. But the good news is that now there's the ACR, the American College of Rheumatology, helped to, I don't know what their involvement was. Of course, they play up their involvement. They helped to push this lawsuit, which they just won in a lower court, allowing for prophylactic colchicine to once again be used generically. So this company that used to make colchicine now temporarily, at least according to this court opinion, can make colchicine again for prophylactic indication. So if that holds up, that would be huge. As if you know, this has been a huge pain in the rear. Anakinra, Mycophenolate, Mofetil. This has pretty much replaced azathioprine in a lot of places. Main uses in lupus and lupus derivatives. It's a purine inhibitor. Again, mainly infectious lymphocytes. Usual dose is 2 to 3 grams divided twice daily or 3 times daily. I've never seen anybody do 3 times daily. So usually 3 grams twice daily is your usual dose you want to get to for severe lupus or nephritis. Horrible nausea, vomiting, diarrhea, more so than some of the other drugs. Can cause cytopenias and LFT, so the monitoring is the same generally as Methotrexate. Anakinra has been shown, it's our go-to drug for lupus nephritis right now, particularly in African Americans and Hispanics. Our other lupus nephritis drug is Cytoxin, but at least in Hispanics and African Americans, Anakinra tends to work better. And then Anakinra is a good maintenance drug for lupus nephritis once you have them into remission on Cytoxin or whatever. So Cyclophosphamide, our big gun, this is kind of our drug of last resort. It's got a lot of uses, most commonly lupus nephritis and vasculitis, but it's also one of these drugs that you can try in any place if you want to. I told my wife, don't let me die without at least 1 gram of Cytoxin, just to see if it does something. It's a derivative of mustard gas, World War I gas. It's a DNA alkylator. Poisons your DNA. Your lymphocytes are very susceptible to this, so they die. Dosing, there's a million ways to dose cyclophosphamide. There's PO, there's IV, there's Euro lupus protocol, there's the NIH protocol. So there's a lot of ways to dose it. You don't really need to know. For boards, I don't think you're going to be dosing it yourselves. The main toxicity is myelosuppression, infection. We don't see as much of the hemorrhagic cystitis. Excuse me. Less common with the IV. And I think most people, at least in rheumatology, we've kind of moved away a lot from the PO Cytoxin to the IV Cytoxin. And it's because of this metabolite, this acrolein metabolite, that accumulates in the bladder. And so if you have somebody on daily oral Cytoxin, there's a continuous supply of acrolein being delivered to the bladder mucosa, which will cause hemorrhagic cystitis and make them more susceptible to bladder cancer. But when you give them the IV dose, it's typically IV, or at least for lupus nephritis, for instance, it's IV once a month for 6 months. So they're getting it all at one time. You give them a lot of fluids, you flush it out, and it's gone, and the bladder's not continuously being washed in this metabolite. And so with IV dosing, probably a lot less of the hemorrhagic cystitis and hopefully less bladder cancer. We also tell patients there's a high risk of non-bladder malignancy. Ovarian failure is fairly common. Generally we tell patients it's age-related. So if you're under 20, you have a really good chance of not having ovarian failure. If you're over 30, you have a really good chance of having ovarian failure. So if that's an issue and the patient absolutely has to have it, some will consider banking, or there's some different strategies to try to get around that. Alopecia, it can happen. The monitoring, you have to monitor it pretty close, and you're watching their white count, basically. You want to try to keep their white count above 3,000. But you would like, you're always kind of riding a balance with cyclophosphamide, but you would like to see them lower their white count. That's how you know their drug is working. Their nadir is going to be about 8, 10, 14 days. So you won't see anything for a week or so. And like I said, it's generally less toxic IV than PO. And then the anti-TNFs, Their indications are mainly rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and IBD. They all have the same toxicities, basically infections. Drug-induced lupus is fairly common, surprisingly common with the TNFs. It's starting to look like if you stay on a TNF long enough, you will get an ANA. So if you have a patient who has an ANA and is on Enbrel, don't worry about it. It's probably just the Enbrel. But some will get drug-induced lupus that actually looks like real lupus, meaning they have renal involvement. Pustular psoriasis is surprisingly common. I've had to stop this several times in patients who they come in and they've got this weird pustular rash on the palms and their soles, classically. And it makes no sense. There's some thoughts about how this happens, but on the face of it, it really doesn't make sense because this is a drug that works great to treat psoriasis. So why the patient comes in with this weird psoriasis after you put them on the drug, on the face of it makes no sense. But there's some ideas behind that. It's relatively contraindicated with CHF. Monitoring, there's what you're supposed to do and what we actually do. Most of your monitoring comes up front. You want to make sure they don't have PPD. They want to make sure they don't have latent TB. You might check a chest X-ray. But these drugs are otherwise fairly clean. They don't really diminish your renal function or your liver function. And so if I have a patient who's doing well on anti-TNF and they're driving from out of town and they're doing fine, I won't really check anything, and I'll see them once a year for their refills, and call me if you have a problem. So some subtle differences in the TNFs. Remicade is an IV infusion, and it's a mouse product, so it works really well, but tends to wear off faster because you develop antibodies to the drug quicker. Works really well, but just kind of limited. Enbrel is once a week. And it's a little bit different because it's all of these are antibodies to TNF-alpha, but Etanercept is actually a TNF receptor, dummy receptor, that sort of sucks up all the TNF. So it's an anti-TNF agent, but it has a slightly different mechanism of action in that sense, and it doesn't work in inflammatory bowel disease, probably because of that difference. All the others are humanized, and it's basically the only differences are how you dose them and IV versus sub-Q. Anakinra at this point is kind of an orphan drug. It was invented for RA, but doesn't work very well. It's an IL-1 inhibitor. It is used for autoinflammatory disease like Still's disease and autoimmune. I've seen it used for familial Mediterranean fever. Daily infection, you probably won't see Anakinra. Tuckson MAB, useful just about everywhere we look. It's an anti-CD20 B-cell depleter. IV works on particularly RA, has been used in myositis. Right now its big use is ANCA-associated vasculitis, so Wegener's now. Rituximab appears to be not inferior and maybe better than cyclophosphamide, and we believe has less toxicity than cyclophosphamide. And then you'll see it used in lupus sometimes, particularly with ITP, but it's not worked as well as hoped in lupus.